Thank you, baby. You're amazing. I know.
We can hear you, Caleb.
All right.
Yeah, you're not muted.
Well, so that you know, Tash is amazing.
Hi, Tash.
Hi.
Hello, Tash.
It is 9:02, so we can probably get started. Thanks everyone for joining Coffee and Cases, and for also learning that my wife is absolutely amazing. Just some quick reminders today. We are setting up a safe space, so we're going to have some really nice conversation around some things that Waldo is going to share with us. Probably very trauma focused. And with that, we have also this session sponsored by LenMed. So Elena, if you are on, you are absolutely welcome to jump in and do a super quick intro. But while Elena maybe gets that sorted out, just a reminder that we're creating really nice, safe spaces for good conversation. Please ask any questions. Please share any thoughts or ideas. Everyone is respected. We are trying to break the silos between EMS, nursing, ED, ICU teams, and really just create one kind of community of practice for really good emergency care. Elena, if you're here, you are absolutely welcome to jump in. Otherwise, we're going to hand over to Waldo. I don't think Elena is here today. Cool. Waldo, it's all yours.
Thanks. Hello. I thought I'd turn my camera on and just say hello to everyone, see that I'm still alive. Cool. Let me get this shared. I wonder, can you guys see the presentation or the whole of PowerPoint?
The whole thing. Now it's coming to presentation mode.
Oh, okay. Then I need to keep that on that screen. Sorry. Okay, there we go. Now it should just be the... sweet. Cool. So what I wanted to chat about today was the idea of penetrating trauma, and how like things in the UK have changed a little bit, and where these things may be applicable for us in the South African setting. So what I'd like to do is just start off with a little bit of an interactive session where I'm hoping I can figure out how to access the chat as a display person. I don't think I can. And then just stab 5, where it comes from, what brought it about. And then we'll go into a little bit about how the nuances that are applied in the southwest of England, where I currently practice, and potentially ways that it can be applied in the South African context and the HEMS context. I think I will definitely say this again, but I think what I want to pass across to you today is not how to treat penetrating trauma. I'm sure everyone's really competent at it, but what I want to do is use a framework that was created by some really smart people that I work with, who I'll tell you about, and how we can remember it much easier, and how this can be adapted for the system in the setting in which you work to try and improve patient outcomes. So this is the interactive part. I might need to use Caleb to read out what's coming into the chat. So what I need you to do in the chat, if you can, is I'm gonna explain the situation and then just write some things, what you think you would do first. So you arrive to a stabbed patient, whatever that patient looks like in your head. They've got obvious blood on their shirt, on their pants in the groin region. They are awake. They're seated next to a wall. They're pretty close to the ambulance. The stabbing happened about 5 minutes ago. The scene is safe, and you're about 15 minutes from hospital. What I want you to do is, there's just some thoughts on some options. If you could just type in the chat what you think you would do as you arrive on scene in your standard practice at the moment. I don't know if that is happening.
I'm
See
just
if I
waiting
can- I don't know.
for some comments to be made. Nothing's been made just yet.
Let me
The
see
chat
if I
should
can
be
join.
open for everyone. Let me just
Just gonna
double
try
check
join on
something.
my phone.
Okay, meeting chat is on, so you should be able to comment.
Anything you guys would consider doing, or even if
Okay,
you
so
feel more comfortable speaking, we can do that.
we've got see where the patient is bleeding from and try and stop it, stop the bleeding, treat life threats, get the patient into the ambulance and treat on the way. Triple H, full primary and secondary survey, expose, stop the bleeding, if possible, get the patient out of the cold. Scoop.
Yeah.
I assume that means
Yeah.
go fast. Assess wounds, stop any severe external bleed, stop the bleeding first, stop the bleeding, treat life threats, get the patient into an ambulance,
Cool.
treat on the way.
Yeah, cool. So that's pretty good. I think the idea of what I'm looking for has started to come through. So let's look into the next part. We're going to be looking to do the same thing. So you're in the ambulance now. What are the types of things you would want to do before leaving the scene? They now have you establish they have a respiratory rate of 26. They don't have any radial pulses. They've got a central chest stab. They've got a left groin stab. They're drowsy and they're pale. Are these any of the things you would want to do before you leave scene? If any, what would you want to do before leaving scene? Yes, I see a hand up.
Look, go ahead. Oh,
I wonder.
Look.
I wonder if it's banned because of presenter mode.
So I have let him use mic, but there are some comments in the chat. So just a lot of.
I can see the chat now.
Really quickly. Okay, cool. You got it.
Yeah, I can see the chat now. Cool. Get moving. FTP, IV vitals, oxygen, IV, start IV, oxygen, IV, TXA, primary, secondary vitals, IV transport, rest on the way. Stop the bleeding. Cool. Anyone else want to add anything into that?
I think keep the patient warm would be really high on my list of priorities.
Yeah, cool. So I don't want to tell you you're all wrong, but I think you'll see throughout the presentation where my thought process is going and why this was created. And you'll see you can do more than you think you can do on the way to hospital instead of on scene waiting. And I'll give you some little bit of evidence and a little bit of just like anecdotes from the unit. There's definitely things that are reasonable to do, but there's also things that are mildly unreasonable to do in these patients. So how STAB 5 came about. So I know it's all abbreviations in the beginning. So Callum, it's Callum Sutton, Mark Kinsella, Matt Robinson, and Fleur Ross. They are all specialist practitioners in critical care, which is what I'm training to become at the moment at Great Western Air Ambulance Charity. We cover from the top of Gloucester down past the Bristol, a little bit of the Cotswolds and Wiltshire, if that makes sense to anyone where we are. And what these four are is they do outreach. So they try their best to go out to crews, offer free education days and things to try and help crews be more confident treating patients, work on little niggles that you can see with certain patient types that come up over and over again, and just try and instill a more mentally shared way of practicing. And what they realized is the stabbing caseload from 2018, 2019 was around 4% of the total dispatches for the unit. And it rose to 10% in 2023, 2024. And in those times, we're doing around 2,200, 2,400 calls a year. So we're looking at 220 to 240 stabbings a year that the team is going to. And something else that was noticed is a lot of the more experienced paramedics within the ambulance service are starting to leave and starting to move on with their careers much earlier than historically would have happened. As we know in the South African context, a lot of people are also leaving pretty early on. It's no different here. Callum and Fleur both worked in London. Callum worked in conjunction with the police on like a little TRU unit. And they saw a lot of stabbings in London. And then Mark and Matt, just as they moved through their career progression, saw more and more stabbings as they moved into enhanced care with the heart teams and then into critical care. And they just felt they had to do something about this incidence of stabbing. And the change that they suggested was initially met with a lot of resistance within the ambulance service. And they did struggle to try and get the idea across of what they were trying to portray. And I'll show you some evidence or just something about STAB5 and the difference that a couple of years can make. So case one is a couple of years ago, 2 pediatrics were stabbed. Both ended up dying. One was within a few minutes of a major trauma center, which would be, I suppose, like a level 1 in South Africa, and one on arrival at the major trauma center. They'd both been stabbed at the same location, and they were both within 5 to 15 to 20 minutes from 2 separate major trauma centers. Both had delayed scene times, and those delayed scene times were things like failed IV access attempts, waiting to mix up Lioplas, waiting for a HEMS team to come to them, and the ambulance is being parked in by other responders. Where case 2, which is more recent, in the last couple of months, it was essentially stabbed pediatric with injuries to his liver, spleen, and bowels. The crew arrived pretty early onto the scene based on the information that they had. They immediately loaded the patient, left the scene. They met their HEMS team en route to the major trauma center. The patient, when met, had severe air hunger, no palpable distal pulses. En route, got IV TXA, 3 units of blood product, and survived. Now, I know when you look at that list of things, pretty much everything there we can do in the South African context, except for blood, which I do understand, and it is a big differentiating factor between the two systems. But everything other than the blood can be done really well in South Africa as well. And that is the message that I'm trying to push across today. The mnemonic came about with a bit of group discussion, and the goal was to try and make something that's easily remembered so that you can reference it. It's become a bit of a verb. Is it a verb? I think it's a verb in our circles, where if we know we're going to a stabbing, we're getting a message to the crew saying, just remember STAB5, and it leads to a set of principles that I'm sharing with you today. That was the STAB5 infographic, which I'll show you, was shared by the charity because it was obviously made in conjunction with the charity. It got picked up on social media by the other authors on the paper, and it was actually published for more widespread adoption and adaption. So far, STAB5 is in 6 of the UK ambulance service. There's 2 in Italy, 2 in Australia, and at least 1 in the US that are all using STAB5 or a variant thereof in their system. And like I said, this is not to teach you how to manage penetrating trauma. It's to empower you to adapt it to your system. It's principles and process of doing things over a standard operating way of doing things. And this also applies to ballistic type injuries as well. Obviously, there is some caveats with ballistic injuries versus knives in terms of your own safety, in terms of the other forces involved with the ballistic moving through the body. So don't forget those things, but the principles are very similar. So this is STAB5. So literally there's 4 things, and then the number. It's scene safety, triaging the patient, assertive scene and patient management, bleeding control, catastrophic bleeding control, and a maximum of 5 minutes on scene. It's penetrating torso injury specifically that STAB5 is trying to focus on. And In the UK context, it's transferred to a major trauma center because those would be the best place for these patients. In the South African context, you have to think about the hospitals around you, which is the most appropriate, which system you're in. Can you bypass smaller hospitals or not? It's very situationally specific. In the UK, we can bypass every hospital to go to a major trauma center. I don't know if you would necessarily bypass a hospital in the far east or the far west to go to somewhere like Barra. I don't know if that makes sense. And then in our context, if the patient is peri-arrest, we would then just go to the nearest trauma unit, because every trauma unit and major trauma center in the UK is funded to be able to give a large amount of blood and to do thoracotomies. So I'm just going to break down each of the things and then carry on from there. So scene safety. We in the Southwest and in England as a whole, the words dynamic risk assessment comes up quite a bit. I initially found myself not liking the word very much. Now I'm using it. Basically means a bit of common sense and making a decision to accept a small amount of risk based on the information available, and that decision changing if more information becomes available. One of the things that was seen as happening, and I'm sure you've seen it in your practice to some extent, is we get told the scene is not necessarily safe. Communication breaks down between the scene and you coming to the scene, and you end up with a bit of a therapeutic vacuum, and no practitioners actually get to the patient, but it's actually safe to attend to the patient. So what we are doing is we turn the lights off. We're in a car, turn the lights off and just drive past the scene. And if there's a lot of bystanders helping, if we see police there, we're stopping, we're getting involved. In the South African context, I know a lot of the private ambulance services work with security companies. That can be quite useful. Police information, if it's available. I think one of the things to remember here is don't put yourself at excessive risk unnecessarily. But remember, we are paid to accept some level of risk just as part of our jobs, as part of what we're doing. Our job is risky, and sometimes it's going to be more risk than others. The southwest of England is not very gun heavy at all. So realistically, we'll know it's a stabbing. We'll be going and we could stay in the car. So if we were unsafe or if the attacker was still around, we could just drive away. South African context, guns, a little bit more of a weighing things up. Do I go into that scene or not knowing where the person with the gun is? Because your car is not necessarily going to keep you safe. So just make sure you're safe, but also accept that there is some level of risk to getting to the patient. Don't allow the patient to sit unnecessarily waiting for care when you could have got there sooner. Triage. In any patient that is stabbed, we should be cutting off all the clothes from top to bottom. We should be actively checking the groin, the axilla, the perineum, and looking for any extra wounds. Even if they tell you, I've only been stabbed once, we should be fully exposing them and looking for more wounds. Once you've exposed them, keep them warm. Obviously, a little bit more relevant to England in the winter compared to South Africa. But still, I think even in South African winter, patients can get really cold really quickly. And we know that the cold isn't good for trauma patients. Keep some dignity. If you're going to cut off all their clothes, try and do it inside an ambulance. Get them covered. Make sure that you maintain some level of dignity for them. When you're checking them, make sure you're checking the front and the back. So your trauma check is literally from the tops of the shoulders all the way down to the groin on the front and the back. And just be looking for small wounds too. Don't just be looking for big knife stab wounds. Look for things like bicycle spokes, screwdrivers. Those are quite important. Make sure if there is a slash wound of some kind or a small wound of some kind, if you can't see the wound bed, it's considered major trauma until proven otherwise. So it is following stab 5 until proven otherwise. If it's a slice, you can see the wound bed. then that's a different conversation. If it's in the central region, still consider using STAB5. Assertive scene and patient management. So this goes to the interactive piece in the beginning. That I think what we end up doing is we end up stagnating on a scene for things. So before we leave for hospital, a large number of you said we'd put in an IV. I think that's fine. But would you have the capacity to say, I'm going to have one attempt at an IV and we're going to get going, and if something changes, I'm going to put in an IO, or I'm going to look en route? We find that sometimes we can get really task focused and you end up 3, 4, 5 attempts. Someone else arrives and they're helping have an attempt. And suddenly we spend 10, 15, 20 minutes looking for an IV when we can give TXA IM if we need to. We can give analgesia intranasally. So I'm not saying don't do an IV line, but consider a stop point that you're cognitively aware of. In our context, we would want an early critical care team request. They can bring things like blood and blood products, thoracotomies to the patient with an early pre-alert to the major trauma center. And we almost invariably will put these patients in an ambulance. We wouldn't fly them just in case we need to do a thoracotomy, that we have the space. In the South African context, if you're on an ILS ambulance, might be worth looking for HEMS or ALS or ECPs early. That will weigh up the delays of your distance from ALS to your distance to hospital, as I'm sure you all have done before. If you're the ALS, getting the call way up your distance to them versus their distance to hospital. And then from a HEMS, especially a HEMS perspective, it is worth thinking about medical aid authorization delays. If it's going to take 15 minutes to get a medical aid authorized and then them to fly to you, it is worth considering, is HEMS the right option for this patient? If they're going to take the patient to the right hospital and there's no time difference or less time, definitely worth doing. Call early to the EDs that you've got a P1 and what's happening so they can prepare. The same thing happens in England. You need to give them time to get their blood ready, to get things ready if they have it available and if they're going to be doing it so that they can do it. If HEMS is an option, in our setting in England, we would shut the aircraft down. The rotors are never running. I know in South Africa we keep rotors running. That's the patient that we definitely keep rotors running for, and we do as much as we can to survive the trip, stopping bleeding, those kinds of things, and doing as much as we can en route. We're not waiting on scene for anything. If you're going by ambulance and you've got ALS coming, meet them on the way. You don't have to sit and wait for them on scene. You can point on the way and you can meet them there. The goal is to focus on moving towards the hospitals that can provide the interventions that you cannot. I think we're lucky in a sense that we can start providing those interventions. We don't carry a lot of blood and blood products, but we can start those interventions and we can do thoracotomies and thoracostomies. So we've got a lot more tools in our toolkit than you would in South Africa. So I think moving towards somewhere that gives you those tools, even if they're not you using the tools, I think is a very reasonable thing to do. And if the patient is walking when you get on scene, walk them straight into the ambulance. Don't get them to sit down somewhere and start an assessment. Walk them onto the ambulance, start your assessment, start moving. Bleeding control is the key interventions wise, I think, and I think the process tells you the same thing. Direct pressure, tourniquets. Remember, tourniquets need to be sufficiently tight to stop arterial bleeding, even if it's painful. So if the patient is telling you that it's really sore, you have to say, I'm so sorry, but I have to do it. At this point, if I don't do this, you are going to die. I need to do this. And you can downgrade them as needed. So if you put a tourniquet on, you then use some hemostatic gauze and see if you can stop it and downgrade the tourniquet. That's perfectly acceptable to do. If you can't downgrade the tourniquet, analgesia, but the tourniquet is important. When you're wound pack with hemostatic gauze, jam as much of it in as you can to create that direct pressure on the wound with the hemostatic gauze, and then you can put a pressure bandage over the top of that. If it's a neck wound, consider early airway management, but it's a big consider your time to hospital versus the potential for the hematoma to grow and what that delay is going to do, and what you have available to you to stop that bleeding, as well as try and improve things in that situation. Obviously, in some services, you have some FDP, and some services do sometimes collect and use some blood. So if you have those things available, it might stave off the intubation happening pre-hospitally to save time to get in to give those things. 5-minute scene time. So 5 minutes isn't like the be all and end all. It's not that if you leave in 4 minutes, you've done an absolutely great job, and if you leave in 6, you've failed. It's just to remind you that the goal is to be progressive and to not do unnecessary things you can't do en route. Like I said earlier, if they're walking, walk them straight into the ambulance. If you can just pick them up and put them on a stretcher, don't waste the time to go and get a scoop and try and roll them onto the scoop. Just lift them and put them on the stretcher. I think it's reasonable to solve catastrophic hemorrhage right where you are, put them on the back of an ambulance, and then continue everything else en route. I think you could argue in situations a couple of other things here and there, depending on the situation you're in, but the priority should be to get rolling towards a hospital. Everything can happen on the way to a hospital. If you're nervous about putting an IV in the back of an ambulance and you're bumping on potholes and going over speed bumps, just stop at a robot, prep everything, pop in the cannula, and then continue on your way. There's no need to not be progressing towards definitive care. In terms of monitoring and TXA, I think you can give TXA intramuscularly. So if you don't have IV access, that's fine. You can also pop in an IO. You can give it IV if you can get IV access. Sometimes in these patients, you would struggle because obviously we know the bleeding trauma patient that's quite far down the line is going to be shut down peripherally, and you're going to struggle. Get any monitoring you can get, but if you're, I don't know, 3 minutes from hospital and you just load them, you start controlling hemorrhage and you get to hospital and you don't have any vital signs, that's okay. The hospital might be a bit unhappy, that's also okay. And within your ambulance services team, they should be supporting you to say they were here within 4 minutes of 5 minutes of arriving on scene. There wasn't time to do these things. They're not that important. You can use things like mentation, color, air hunger, pulses, capillary refill, and you can kind of use those surrogates for their cardiac output in the initial phases if it's going to be a really short trip, and just get them in. If time is allowing, analgesia, obviously, because they've been stabbed or shot, which will be painful. And if you put a tourniquet on the tourniquet, if you don't have access, you can use things like Penthrox. You guys can use intranasal ketamine or fentanyl. I currently could probably only use Penthrox and ketamine. I would just err on the side of the doses you're using in the obtunded patient, because you don't want to make them more obtunded by giving them a lot of ketamine or a lot of fentanyl. And these 2 articles, I'll send them on to the WhatsApp group after this. I think these are the 2 that definitely changed the way I think about things. So the top one is from London HEMS, and they did a review of all the thoracotomies they've done pre-hospitally since 1999 until I think it was 2023. And what they found is patients in traumatic cardiac arrest with cardiac tamponade, there's no survivors beyond 15 minutes of traumatic cardiac arrest, and there's no survivors after 5 minutes for exsanguination. So basically, if they get into a position where they go into arrest, the likelihood of survival is really, really low. And with the second one, with the 8 memoir, which is what we're talking about today, 50% of deaths in hospital after penetrating trauma is exsanguination. Obviously, you can't necessarily just take that on, take it pre-hospitally, but I think it just shows you exsanguination kills people really quickly. And if we can do things to stop that exsanguination and take them to a place where we can try and refill them as quickly as possible, we actually will improve their outcomes. So now when you look at this infographic, I don't want you to just see a bunch of things that are, oh, these are just things we have to do. What I want this infographic to do for you is just let you think, how am I going to look at penetrating trauma going forward, and my thoughts on how that works. I know from personal experience, I have sat on scene with stabbed chests and gunshot chests and taken the time to put up an IV and give them analgesia. And is that the right thing to do? Well, they survived, so it must have been. Not necessarily. So I think when you see this thing, see how do I change my system to try and get these patients to hospital faster. Scene times directly correlate to patient outcomes, because you do find time just getting lost along the way, getting parked in, trying to get medical aid details, waiting for HEMS off, the police need to have a conversation. All of these things add time to a patient group that there's very little you can do about in the South African context outside of stopping the bleed and giving TXA. We can give fluid, but it's not going to replace the blood that they've lost. You need to get them to a place that gives them that blood and gives them those procedures that they might need to improve their outcomes. So my take-home messages: don't let your patients wait on scene for literal life-saving things. If the scene is safe, please approach. Don't sit around the corner waiting for 15, 20, 30 minutes for a scene to be safe. I think in the UK, the Manchester Arena inquiry for the Manchester bombings, they saw a lot of that vacuum happening, and there's quite a drive in the UK to get people closer to patients quicker. Like I said, with the scene safety thing, obviously don't put yourself at unnecessary risk, but remember, we do get paid for a small amount of risk. And if that means driving past to have a look if you can get to the patient, it's worth doing. Stopping the bleed aggressively, wherever that bleed may be, aggressively trying to stop and halt that bleeding. Everything can be done on the way to hospital. I know I've written in brackets there, HEMS aside, there's some things that you can't do in the back of an aircraft. They're just not big enough. You don't have the space. Then it's worth considering, is there a couple of things I do before I leave or not? And maybe revolutionary for the South African context, do I maybe, instead of flying this patient 4 minutes to hospital, drive with them in an ambulance for 10, and the aircraft can come and fetch you later? Don't waste time on scene for anyone or anything when you're in a transport capable resource. If you could put the patient in the back of an ambulance and you're spending 15 minutes looking, I don't know, for a medical aid card or something like that, or the police want to have a conversation, it's not appropriate. Get your patient to a facility. This is not scoop and run. This is quick assessment, scoop them, stop the bleed, and intervene in the ambulance while you run. So we're not just scooping them, traditionally scooping and doing nothing. We're loading them as quickly as we can. We're starting to move as quickly as we can, and we're doing everything on the way. And I urge you that, and I probably said this 4 or 5 times because this is the most important thing. I want you to take this idea and implement it in your system for you, your teams, your patients, and how your local infrastructure works, to see how you can use this same tool in your space. It doesn't have to look, it doesn't have to look like this, but an idea of this, that you can share a mental model in your team of how you're going to manage penetrating trauma that's central. How are we going to look after those patients? is useful to your team and to your patients. Thank you very much for letting me talk today, guys. I think what I'd like to do now is, obviously, if anyone has any questions, that'd be awesome. But maybe just to share some thoughts on what this could look like in your system. I think that'd be really nice.
So maybe I'd like to just jump in and really reiterate what Waldo said just around times. And I think sometimes we think that HEMS is going to be faster, but the data we have really suggests that HEMS is not always faster, especially if the patient is close to a facility. So there might be some frustration around, but I'm phoning the helicopter because I want the patient to get to a facility quicker. And in the last little while, we've definitely been doing a lot of reflection around when do we actually get a patient to a facility quicker. And it's usually when we're more than 70 kilometers from the closest facility. Because there's obviously, on the HEM side, there's an activation time, there's a flight time. The patient, if they are so close that the flight time is so close, then you're probably close enough to another facility to be able to get to that facility. So if you are within around 70 kilometers of a facility, the chance is good throwing that patient in the ambulance, treating them en route, and getting them to a facility is going to be far quicker than what the helicopter could do. And then from there, it's a little bit easier to move them to a better facility if the outlying facility is not the correct one for their long-term progress. Definitely support the idea of just moving fast.
So in our setting, just based on our major trauma center for the pediatrics and adults is in Bristol, we've figured out, well, the team have figured out, not me, that anything that's within a 40 to 45-minute drive is faster to drive than to load the patient in the aircraft, because you end up having to drive the patient to the aircraft, load them in the aircraft, start the aircraft, fly them, land on a helipad, and then the transfer from one of the PEDS major trauma centers, an elevated helipad. So you then have to ride the lift down into the adult hospital through that. So it takes like 10 minutes to get from a shutdown aircraft into PEDS ED. And then it takes 15 minutes to get them loaded. And then let's say 3 minutes startup shutdown either side. So I think that is definitely a very valid thing to think about. I saw some questions. Sorry about the slides, guys. I didn't see that until after. I hope it got better. I don't know, sorry. And then someone asked about downgrading of the tourniquet. I see Sean did reply to that. Okay, cool. Yeah, Richard. Stop sharing. Oh, stop sharing.
Hi, yeah, can you hear me?
Yes, hi.
Hi. Thank you very much for a very informative chat. And good luck with the rest of your studies. Just a quick one. When it comes to your stabbings, I joined, unfortunately, and then I lost the link and I had to rejoin. Do you guys have a lot of stabbings regarding bicycle spokes in the UK, as it is becoming a bit more of a problem here in South Africa?
No. So I specifically spoke about that because of it being a problem in South Africa. I think what I wanted to do was just show that there is some similarity between the two ways of practicing, but that you could take some of it and leave it in England and take more of it and put it in South Africa. So that was just a comparator between the two to show and just to help remind you guys to think of some other stuff. I did see another hand. I don't know if it's been put down.
Sean had his hand up.
Hi, Waldo.
Hello, Mr. Green.
Nice to hear from you. It was fantastic. Thanks. I know now I joined late. Just so you know, there is a fair amount of research happening around tourniquets in the current situation that I'm at, where Israel and Hamas are having the issues. There is research coming out of there around tourniquets, and there's a nice paper currently that's come out, which I'll put into the chat. Around anything longer than 4 hours, they're seeing that if you keep it on for longer than 4 hours, your tourniquet, you're seeing primarily an 80% chance of amputation. So that's just something, and it's going to be good to see what the new research is saying.
Yeah, I think that's completely valid. And I think that's why I specifically mentioned the downgrading of the tourniquet, So remember, once you put a tourniquet on, you can release it and put it off. It doesn't
100%.
have to stay on because you've put it on. And I think
Correct.
that'd be cool. If you send that article, that'd be cool to read for more context on that.
Awesome.
And just remember, guys, if you're going to put a tourniquet on, just write the time you've put it on the tourniquet, and make sure that's very clear in your handover when you've put the tourniquet on, so that they know how much time they have to downgrade that tourniquet. Any other questions from anyone? There we go.
Hey, good morning, Waldo. Tom.
Morning, how are you?
Right, and yourself. So for
Yeah,
some
very well,
reason
thanks.
I cannot put my hand up, hence I jumped onto the mic. So
Yeah, no worries.
I'm not being cheeky, but that's what it is. Thanks for the presentation. I think it just highlights again, don't stay and play and treat en route. That's the very important message. And if I may, I just want to share a personal experience that speaks to this whole presentation. 46 years ago,
Very
I was
lovely.
a gunshot chest, gunshot arm. I was 15 years of age. I had a hemopneumothorax and I had a brachial artery that was gone. Okay. No paramedics
Yep.
in the day, no advanced life support. Ambulance arrived while I was lying there bleeding, 4 adults watching me bleeding to death, doing nothing. Not because they didn't want to, obviously they didn't know what to do. And from the time of injury, I had no pain, thankfully. Ambulance arrived, bandaged, put me in the back and rushed to the Joburg jail. And without question, that's what saved my life. So sometimes the basics, not sometimes, most of the time, the basics is what's going to save your patient. And as you say, don't get focused on, oh, I've got to get an IV. Oh, I've got to get it. Do the basics and get going. We know that time away from the surgeon is critical, and I'm living proof thereof. So
Thank you
thanks
so much
talk.
for sharing personal experience. Thank you. I think we have someone in the community of us practicing that's literally alive because of that now. David.
Good morning, Waldo. Very nice presentation that you did.
Thank you.
Just maybe coming on to what Caleb and you were discussing a little bit on the HEM side of things. When do you make that decision to stay and play or to scoop and go? I work in a very large, we're talking 126,000 square kilometer province, and most of it's rural. So hospitals are fairly there. There's about 42 hospitals in the province, but those hospitals are not geared up, as to say, maybe our tertiary or our academic hospitals. So, we sometimes, in most of the cases, when we activate HEMS in Limpopo, we would activate it purely based on the time of getting to the patient. And we must also not always think that the helicopter is a mode of transport. It is a mode of transport, but it's also the way I view the helicopter is to get that expertise. Even if the patient is in a hospital, I think Caleb can attest to the fact that some of the doctors here really don't have some of the skill sets, but also to get the right people who have got those skills in half the time to the patient, if you understand what I'm trying to say. So the HEMS service here is not just only a mode of transport and large distances, but it's also to get the expertise to the scene or to the hospital to say, yeah, we can help. And I think therefore we can decrease some of the deaths that are happening. But unfortunately, it's sometimes you have to skip the nearby hospitals because nothing's going to happen there. Basically, you have to go and get to your major trauma center or get to the most appropriate facility in a shorter space of time. We've got a lot of data that we've collected over 3 years that we can show where there was delayed intubation, the outcomes of the patients, and the large majority of patients that we do transport are peds and neonates, and of course obstetric emergencies, because it takes up to 6 hours, 8 hours for a transfer by road to maybe an academic or tertiary institution. So most of the time that is for time and getting the expertise onto the scene. So I think that's very important to keep in mind. A lot of people in our circle or in our practices and in the profession that we do, will maybe want to do step 1, 2, 3, 4, and 5. And as the previous speaker has spoken, maybe it's just sometimes the basics. Stop the bleeding, get the patient in the ambulance, try get to even any hospital or a stable situation where you can then continue your transport. But yes, I don't believe in staying and playing. I believe in getting the patient to the best facility as quickly as possible. But that's from my experience in Limpopo.
Yeah, I fully agree with you. I was still working at Rocket when you guys started working together, and I do agree. And I see Dagmar's just spoken to the same point. That's something I didn't understand when I was in South Africa, is necessarily the idea of bringing the expertise to the patient. In the last year and a bit, I've only put 3 patients in the helicopter, and that's not because we're not treating a lot of patients. So I think us getting the right people to the right patients in the right time frame is just as important. But I don't want anyone to forget or like to downplay the need in these patients to still start moving, whatever that route may be. So I know, let's say in the Limpopo setting, you're going to be 6 hours from an appropriate hospital. That's fair. And maybe it works that you can start driving and meet somewhere on the way at a different hospital that's en route to try and get the best of both worlds. But that's obviously something that you'd have to look at for your system.
Great, thank you.
Thank you so much for sharing. There were a couple of questions in the. Randani says, in Mpumalanga, in the area I'm working, it's better to activate HEMS for some patients, as transporting to hospital will delay more on the admin side, as they want to check network hospital co-payments. So yeah, that's one of the things I didn't want to say too outright, but medical aids are a problem for these patients, especially if there's any sort of things there. And then Moira asked, how long can you release the tourniquet? So basically the idea is you put the tourniquet on, you try and stem the bleeding, and then you take the tourniquet off in its entirety. So what I do is, if the tourniquet is on my arm and I've tightened it, for instance, and I've managed to stop the bleed, I'll then just release it and leave it here. So it's not restricting blood flow, but I have been able to stop this wound without excessive hemorrhage. And then the idea is to not have to put it back on. But if you start to release it and you see bleeding again, especially arterial bleeding, or most importantly, just tighten it back up and leave it to the hospital, and then they can put a suture in or something like that. Sandile says, in Cape Town, Stab 5 approach fails before it even starts due to the hostile dynamics that exist in the areas, and you have to wait for the police. So that is a limiting thing. I think that is also a very South African way of practice. I'm sure there's other places in the world that practice the same, where you end up with that vacuum just because it's just too hostile to get to the patients. But that doesn't stop you from implementing the principles when you get to the patients, and trying then to continue pushing the principles forward. And then Ange says basics are the most important, is what our lecturers always said. We definitely talk about this. Yeah, often, yeah, but I need to do this. Police, traffic, yeah, exactly. Stay in place for regular diabetic patients who default and have sugar crashes. Yeah, so I think this is definitely a patient grouping that's very much on this side of, we're not doing that much before we get moving if we can. And then you have those patients that you can stay and play with for a little while. The 80-year-old with a neck of femur fracture that you want to slowly give morphine to try and get their pain under control before you take them out of bed. These are two very different patient groups. Yeah, and Sean says systems can either be positive or negative in terms of how the activation occurs. I'm guessing that's HEMS activations. Is there anyone else who has any other questions or any other thoughts about how or what this looks like in your local system that they want to share? And if there's anyone not from South Africa who's practicing in another country,
Yeah, Waldo, Tom again.
yeah,
So having practiced in South Africa for many years, I'm now practicing at the moment in Saudi Arabia.
yeah,
And we do lots of trauma. I would say 80+% of our HEMS is trauma. But what we do also is and we all do this, we ring fence scene time as much as possible. So before we get to the scene, we'll say, okay, we're going to aim for a maximum of 30 minutes, depending on the case. Obviously, in this case, you're pushing it much quicker. But in saying that, we also do lots of meet over points. So the crew will be on the ground, they'll do the initial stabilization, they're coming towards the bigger center, and we'll do a meet over point halfway, land, pick up, go. So that we're doing here as well. So, yeah.
Yeah, you've obviously got a lot more space to do that, especially when you move out of the city. It's a lot safer. Yeah.
Yeah, exactly.
Awesome. Anyone else from any other systems around the world that wants to share? Anyone anywhere else in the Middle East, in Oz, in the UK? Cool. Sweet. I think, Caleb, if there's no other questions, I will hand the floor back to you for closing. Unless you want me to do it. I don't know if there's anything you need me to do, but...
No, thank you so much for the presentation, Waldo. And we're looking forward to the airway one that's coming up soon.
Yeah, definitely.
We don't have a date yet.
I'll talk about it. I'll bring a case to you guys in the near future once I've got...
Awesome.
Oh, I see some more things. I found it easier to activate HEMS than dealing with a hospital because HEMS critical care is able to find the most suitable hospital for the patient in the network. Fair enough. And then at MSC, they use the NHS standards. So yes, Sandile, this is only starting to go into NHS stuff. So I'll put it on the group. Then you can have a good look at it and maybe share it around your teams at MSC. Sorry, Caleb.
Thank you so much, Waldo. I'll appreciate that.
Yeah, no worries. I'll put it on the group for you. I should do that right now.
Okay, so thank you everyone for joining. The word of the day is going to be STAB, and the link will be shared super shortly. If I can just also do a super quick reminder just to say thank you to LaneMade for sponsoring this session again this week and for making it possible for these sessions that are sponsored to be completely available online on the YouTube channel. If you haven't had a look at the YouTube channel, it's a really good place to go and see all of the previous ones. And then other than that, you must have a fantastic day.
Cheers, guys. Thank you so much. Have a good day. See you soon.
Thank you. Bye.
Thanks, Waldo.
No worries. Best of luck.
There are some hands up. I don't know if you guys meant to put hands up.
I'll just hang around for a second.
Morning. Sorry, I just want to know, thank you for the presentation. I just want to know, is there an attendance register?
It's coming. Just give me 1 second.
Okay, thank
My
you.
computer has decided at this point to freeze.
Hey, Waldo. I was supposed to join you in January there. I turned it down. I came to MSC.
Oh, that's disappointing. No, I don't think you made a bad decision, to be honest. I think spend some time doing that and then figure out if England's for you, man. The practice is different and not everyone gets into critical care teams. So the practice is different. How is MSC? Is it okay?
Yeah, well, it's okay, but they're still starting. They're still introducing the paramedics into the system. So there are limitations here and there, but they're trying to allow us latitude to be who we are, you know. But it's quite an enclosed environment, so you don't really do advanced life support stuff unless if it's really a dire emergency. It's just mostly primary healthcare stuff, which is nice.
But I
I
think it gives you, though, it gives you a space if they're just starting out to hopefully help shape their system and shape what you want the system to look like. And I don't, even if it's not a lot of emergency care at the moment and it's more urgent type primary health care, you can still find ways to improve that for yourselves and hopefully maybe make the system better and easier for the people who come after you. That's really cool. It's cool to be at the start of a new system with a new idea of what practice looks like in a certain space.
Yeah, for sure. Yeah, it has its challenges though, but we're navigating through, and hopefully someday those who come after us will be happier.
That's exactly it. It's always about who comes after you, leaving it better for them.
Yeah. Well, it's not really an environment where one should stay for long, unless if you are 55 and you are in your retirement stage, then you can come and sit here. But for us who are still a little still fresh, it shouldn't be long. You lose, because you lose touch with a lot of other stuff. So yeah, I might just contact the recruiter that side and, you know, tell them that I'm ready to come over, because there's some other stuff that I like in the NHS, like the prescribing and everything. That is nice, when, especially if you are aspiring to work in remote areas, it helps a lot, you know. So
yeah, it definitely does.
It's also a good environment. Yeah.
I think the one thing I'd say about the UK and practicing here is having plans is all good and well, but I can guarantee you they take a lot longer to achieve than you think they do. So I think I was really lucky to get into a critical care team when I did. If you can't evidence 2 years of practice beforehand, they'll start you off as a newly qualified paramedic, so you have to do that for 2 years. So there's a lot of little barriers because the NHS is so different to where we come from. And there's a lot of basically tick boxes you have to do to be able to fit into the system. So Sheridan's done prescribing, and it was a really good course. She's now an independent prescriber, but it was done privately, so it can be quite expensive. So I think come across definitely, but just accept that it's going to take you a couple of years to get things moving and things done. It's not like South Africa where there's a shortage. There's still a shortage of people here, but there's not a shortage of people here for moving careers forward into other places necessarily. So it is quite hard to find, like when you do prescribing, you need a mentor, to find a service that allows you to have a mentor and then to use your prescribing. But that stuff is really cool. And if you can get into those positions, being in the UK is honestly, it's life-changing. My practice is completely different. And I'm coming back in October for a couple of days to work with everyone and just see how different my practice has become. But yeah, definitely do it. If you're looking for it, definitely do it.
Yeah, I'll consider it. I'll consider it at some stage. Thanks, man.
Well, no worries. It was cool to chat to you.
It's actually 4 o'clock in the morning where I am. I'm in the US, actually.
Oh, nice. So did you stay up late or did you get up early?
I actually have a patient in the clinic, so I've been up. I've been up since yesterday, since last night rather.
Well, best of luck with that.
Yeah.
I'm going to be going. I hope you have a great day, and I'll catch everyone soon.
Cool. Hundreds, man. Thanks.
Cheers. Bye-bye.
Cheers.